Okay, so the maxillary premolar, the areas that you'll see on the maxillary premolar that'll be radiolucent will be the maxillary sinus, and then the areas that you would expect to see that are radiopaque would be the zygomatic process. Now this can get confusing because you're going to also see the floor of the maxillary sinus, and sometimes people get confused between the zygomatic process and the floor of the sinus. So we'll look at that and figure out how we can tell one thing from the other. Okay, so when we are looking at, so here is the actual zygomatic process right through here. And then over here is where the sinus is, maxillary sinus. And then so here we can see the zygomatic process. It's thicker and a little bit dark, more white. And then the actual maxillary sinus is a little bit thinner radiopaque line. And then you can see the actual sinus area above it. So the zygomatic process is a U-shape or a J-shape radiopacity, often superimposed over the roots of the molars and the maxillary sinus. So especially when using the bisecting angle technique. So what you kind of start to see is you can see here it gets really thick through here. But you can see this kind of J-shaped or U-shaped. And then there's also kind of an inverted Y appearance when you're looking at a more anterior film as well. But usually you can see down here is the sinus, up here is the zygomatic process. And it looks thicker and like a brighter white. So again, here's the zygomatic process and here's the floor of the maxillary sinus. So what are the arrows pointing to? Are they pointing to the zygomatic process or are they pointing to the maxillary sinus? The maxillary sinus, the thicker part here is going to be the zygomatic process. And this is going to be the maxillary sinus. So in a maxillary molar, again, we can see the zygomatic process, and you can see how it's going to be a thicker radiopaque area. You're going to see the maxillary sinus kind of along the tops of the molars. You may see the coronoid process from the mandible, and then you're going to see the maxillary tuberosity, which is way in the back after the last molar. So here you can see we have the maxillary tuberosity back behind the most posterior molar. And then we have, where's B? And then here it would be like if you could actually see it in the skull, then the coronoid process would be popping up about here if you could see it. And then C is the zygomatic process. You can see where the zygomatic process runs through here. And then the maxillary sinus would be below it through here. So here's the coronoid process. This actually looks just like a tooth, so I think the maxillary tuberosity would be back even further because I think this is their wisdom tooth. So you could say if the tooth wasn't here, or in the meantime, you know, I guess the landmark could still be the maxillary tuberosity, but this actual white piece, I'm almost positive, is the wisdom tooth. But this is the area where the maxillary tuberosity would be. C is the zygomatic process, right in here. And then as we come down into the maxillary sinus. So here's a much better picture. So you can see that perhaps they had a wisdom tooth removed or something, but this is a much more accurate, for me, image of a maxillary tuberosity. And then it's just you can almost feel it with your tongue or put your finger back there and feel the bone after the most posterior molar in the mouth. And then here we have maxillary sinus and the zygomatic process. And then the coronoid process, they've put it in the little picture here, but here it is in an x-ray popping up from the bottom. They've got a couple extra teeth. This is like, they got a wisdom tooth here and a wisdom tooth there. Okay, zygomatic bone process or arch. The zygomatic bone is the white arrows. Start in the anterior aspect with the zygomatic process being the blue, so as it comes forward. So as it thins out a little bit, that's the blue, which has the U shape. So here you can see the U shape. Here's the thicker, actual, like more thicker bone part of the zygomatic bone or arch. And then it thins up as it comes more anterior. The maxillary sinus would run right over, kind of superimpose over the molars there. Here's a little bit of a coronoid process. Down here you can see a tiny bit. Here's the floor of the maxillary sinus through here, and zygomatic process through here. And you can see that real J, kind of that J shape right through there. And it's thicker back here. So that's what it's saying, is it's thicker where it's the zygomatic bone, and then the process is more where it thins out. Okay, so the zygomatic process is where it thins here. The maxillary sinus is up through here. It kind of comes along the whole way here. The coronoid process, this comes in quite a bit. I don't know if there's some distortion there. And then the maxillary tuberosity is the tissue back behind the last molar. Okay, mandibular incisors, what you would expect to see on many images of the mandibular incisors would be sort of a little bit more of a radiolucent area that would be the mental fossa. This may or may not be obvious in pictures. I haven't always noticed it in all the incisor images that I've taken, but right kind of midway through the roots there would be kind of a large depression there, kind of a more radiolucent area. You notice that it doesn't include the apices, so it's kind of in between all the roots of the incisors. A little bit thinner bone area. Then you'd have a thicker bone area. This might be an area where sometimes people have tori, mandibular tori, but if they don't, it's just a thicker area that is the mental ridge. And then they're going to have a radiopaque area that's sort of encircling a radiolucent, kind of, it will look like a real small dot. So the genial tubercles are going to surround the lingual foramen. And the genial tubercles are areas that are kind of muscle attachments that help move your tongue. So that's what the more radiopaque area, and then the lingual foramen is where the nerve exits. So a lot of times, if you see it, you might see both of them. Or if the foramen is really tiny, you might not see it as well. So here you can see how there's a thickening of the bone around the foramen. So here's the lingual foramen, and here's the genial tubercles. And then C is the right, you can sort of see along here and here. This is the mental ridge. And then there's a bit of a depression right through here where the bone is thinner, and that's the mental fossa. So here you can see sort of a thinning of the bone here. It would be the mental fossa. Here's a really good picture of the incisive foramen and the genial tubercles. And let's see. Here's the area of the foramen on the skeleton, or on the skeleton, I guess. And then this is interesting. This is showing an anomaly, and this is a canine sort of twisted sideways, and you can see that it has a bifurcated root. So it's got a double root, which is definitely an anomaly for a canine. So here again we have the mental ridge right down the front. It shows up really well here on this radiograph, the mental ridge. So it's commonly seen when doing the bisecting, and that's because you'll kind of look down a little bit more at more of a steeper angle, and so you'll pick up the denser bone there. And then here, so this one is showing the mental fossa more toward the apices, so I guess that would be an important area to note so that you didn't think it was a huge area of like a pathology, like a huge abscess or something. So the mental fossa appears as a radiolucent area right above the mental ridge. So I guess the area can differ. On some people it might be higher, and in other people it might be lower. But that's something to kind of note. If the patient doesn't have any kind of symptoms and there's no caries or inflammation, but you see sort of a radiolucent area, then you know you're probably looking at the mental fossa. The radiolucent area above corresponds to the location of the mental fossa, but this is pathology. So if you look at how much darker and how this sort of encapsulates right along, also, and it kind of stops here, but it's really, really dark. And then it sort of goes along with the PDL, like the PDL kind of widens right here. So this is pathology, and it's a lot more isolated. Doesn't include this tooth at all. Like it doesn't include the bone here or over here. It just includes these three incisors. And then there's a much, much darker area. So this would stand out as pathology as opposed to this where it's lighter. You can see the difference. There's still a lot of bone here. It's just not as dense as like down here. And then if you look at the area with the pathology, it's much more radiolucent. So there's much less bone here where there's infection. The orange arrows above identify nutrient canals, so that's kind of interesting. So you see these little streaks coming down from the incisors. Those are nutrient canals. A nutrient canal, let's see where it said. Oh, no, I guess my notes don't have it. Okay. So now we'll look at mandibular canine radiograph. So of the radiopaque images, we would see a mental ridge coming off the side there still, right until probably about to the canine. We're going to see the mental foramen. This is usually right between the premolars or maybe off to one premolar more than the other. We might still see a little bit of the lingual foramen and the genial tubercles if we're more anterior, especially if our canine's not centered. And then we could see the inferior border of the mandible, depending on how vertical our angulation is. So here we can see the mental foramen over here, kind of a side shot, and we can see the mental ridge here. And then here we can see the genial tubercles and the lingual foramen. Again, the mental ridge. You can see it's a thicker bone, thicker area of bone. Lingual foramen and the genial tubercles surrounding it. And then here we can see the mental foramen. Kind of looks like very often, especially if you're not used to seeing it, people can mistake the mental foramen for pathology, especially if it's located really close to an apice of, if you take an x-ray at a certain angle and it superimposes it over the apice of a premolar, someone could be very likely to think it's pathology and not the foramen. So it's important to be aware of its location and what it is. In the mandibular premolar shot, we're going to see the mental foramen. We quite possibly could see the mandibular canal that houses the nerve there. We could see internal oblique ridge possibly superimposed there. And then we can see sort of more of a radiolucent area, which would be the submandibular gland fossa. So here on the skeleton, we see the foramen, and this is where the mandibular canal is. Internal oblique ridge, and the submandibular gland fossa. You can see how it's kind of a scooped out, hollowed out area right below the ridge. So here we have the internal oblique ridge. And the ridge runs downward and forward from the third molar region to the area of the premolars. And you can see the submandibular fossa down here. It's more of a radiolucent area. And again, submandibular fossa, big radiolucent area. Mandibular canal runs downward from the mandibular foramen to the mental foramen, passing close to the roots of the molars, is below the internal oblique ridge, and has thinner radiopaque lines. So I don't think this is a great image of it. There's a little bit of a thin line here. You can see some of it, but this big radiolucent area is the fossa. So let's see. There'll be more pictures, I think, to come. So here's the fossa again, the submandibular gland fossa. Here's the mental foramen, usually located in the area of the premolars, may mimic pathology if superimposed over the apex of one of the premolars. So just knowing that that is typically there. And mandibular molar, we have the external oblique ridge, the internal oblique ridge, the mandibular canal, and then you can see the borders of the canal will be radiopaque and the canal itself will be radiolucent, and then the submandibular gland fossa. So here the canal would run along here. We have the external oblique ridge, and then we have the internal oblique ridge, and then the submandibular gland fossa. So here we have the fossa. You can start to see the mandibular canal, the thin radiopaque lines of the canal. And then you can see the internal oblique ridge and then the external oblique ridge. So these lines here and here. And then the border of the mandible down here. So here again we have the external oblique ridge and the internal, or the external and the internal. Again, the external and the internal. And the internal oblique ridge. And it comes really radiopaque right along the roots there. Submandibular gland fossa. And then we can see the mandibular canal pretty well right through here, over the gland fossa, submandibular gland fossa. Showing lots of pictures of the submandibular gland fossa. Make sure that you remember that whole phrase so you can write it out on the landmark exam, submandibular gland fossa. If you put your tongue down in the kind of the floor of your mouth and really off to the side, you can kind of feel those glands, and we palpate it with our fingers too during our intra-extraoral exam. A depression on the lingual side of the mandible below the mylohyoid ridge, the submandibular gland, is located in this region. Here's our external oblique and our internal oblique. Here's the mandibular canal running along the base of the molars. And it runs very close to the roots, so they got to check that out when they're going to extract wisdom teeth to make sure that the roots of the wisdom teeth are not really wrapped around the nerve or coming into that mandibular canal. These are some crazy impacted teeth. That is just as sideways as you can get. And this is the second molar, I believe, which is just as impacted as the third. So that's definitely a hard situation. And then here you can see this wisdom teeth. See how incredibly turned up these roots are? So this would be a really difficult extraction, and it lays right over the nerve. And so this could easily cause the patient some residual numbness. So doctors shy away from extracting teeth when they see these conditions, the twisted roots and how close it is to the mandibular canal or the nerve. Okay, so we're going to stop there, and then we'll pick up in the next chunk.